Damos comienzo a la segunda jornada de nuestro simposio. Estoy junto al doctor Sexer, que es médico de planta de nuestro hospital, del Hospital Fernández, y jefe de neonatología del Sanatorio en Chorena. Y mi nombre es Liliana Roldán, también soy médica de planta del Hospital Fernández. Vamos a escuchar a continuación las conferencias de la doctora Anne Greenough, profesor de neonatología y fisiología respiratoria, directora de educación y capacitación en The King Health Partner Academic Science Center. A continuación, al doctor Roger SOLL, profesor de neonatología en la Facultad de Medicina en la Universidad de Vermont, vicepresidente de la Vermont-Oxford Network y coordinador editor de la Cochrane Neonatal. Y finalmente, al doctor Martin KESLER, profesor de pediatría, presidente del Institutional Review Board, director médico de la UCIN y ECMO de la Universidad Brown. A continuación de las presentaciones, tendremos un debate de preguntas con la mesa interactiva.
You can see a relatively modest level of supplementary oxygen predicted CPAP failure. So what can we do if CPAP is going to fail? Well, one thought is to use nasal IPPV, and this can be synchronized, non-synchronized, or a hybrid. And in these meta-analyses, NIPPV was associated with a reduction in need for reintubation and air leaks, but no differences in bronchopulmonary dysplasia, death, or necrotizing enterocolitis. But if we are going to use CPAP, how do we wean from it? And there are sort of two modes of doing this. One is gradually weaning the pressure, and the other is just withdrawing CPAP. And in this first study, CPAP was reduced 1 centimetre every 8 hours against sudden withdrawal. And in the gradual weaning was more successful at first attempt. But interestingly, that did not result. Ladies and gentlemen, good afternoon. I'm delighted and feel very honoured to be asked to give you this talk on optimal methods of invasive and non-invasive respiratory support for neonates. This is a huge topic, so I'm going to have to be rather selective in the studies I present to you, but I've chosen those that make important points, or maybe just to show you that certain of these areas are pretty controversial. Before I start going into the studies, I want to talk with you about something very important. This is a 26-week gestation infant who's clearly ventilated. And the parents want to know what will be the outcome of their baby. Now, in trials, we often use survival without bronchopulmonary dysplasia as the major outcome. But more important to parents and society is the chronic respiratory morbidity these little babies will suffer, maybe into adulthood. And interestingly, I argued about this in my New England Journal of Medicine editorial when assessing a very good large randomized controlled trial of hydrocortisone, where again the outcome was survival without bronchopulmonary dysplasia. Now let's move on into the actual studies. starting first with non-invasive respiratory support. This was a recent study done in the UK and in Italy, which demonstrated that non-invasive respiratory support was more commonly used in Italy, but there they used CPAP more commonly than high flow and different flow rates of high flow than used in the UK. And one of the important points I want to make is where there is variation in practice, this suggests a lack of evidence. Thinking about prophylactic nasal CPAP. In this Cochrane review, 3 trials were looked at which showed a reduction in BPD or death, mechanical ventilation, and the need for surfactant. So what's not to like about those outcomes? Well, the problem being that CPAP does not always succeed. And in this very large study from Derived et al., nearly half the babies who were looked at 25 to 28 weeks of gestation, CPAP failed. And in those that failed, there was a higher rate of death, or BPD, and importantly, longer durations of respiratory support and length of stay. In this smaller study, there are the similar increased risks of death, and in this time, pneumothorax and bronchopulmonary dysplasia. And you can see a relatively modest level of supplementary oxygen predicted CPAP failure. So what can we do if CPAP is going to fail? Well, one thought is to use nasal IPPV, and this can be synchronized, non-synchronized, or a hybrid. And in these meta-analyses, NIPPV was associated with a reduction in need for reintubation and air leaks, but no differences in bronchopulmonary dysplasia, death, or necrotizing enterocolitis. But if we are going to use CPAP, how do we wean from it? And there are sort of 2 modes of doing this. One is gradually weaning the pressure, and the other is just withdrawing CPAP. And in this first study, CPAP was reduced 1 centimetre every 8 hours against sudden withdrawal. And in the gradual weaning was more successful at first attempt. But interestingly, that did not result in difference in CPAP days or length of stay. In a larger study, similar outcomes, no significant differences in weight gain velocity or secondary outcomes, but in the very immature infants, those in less than 28 weeks, they were more successfully weaned in gradual reduction in pressure. Now, which method of administration? Well, these are several studies which have looked at nasal mask versus binasal prongs. And in the first study, where both groups received bubble CPAP, there were no significant differences in the inspired oxygen level at 24 hours, or indeed CPAP failure. But nasal trauma was lower in the mask group. In a review of 4 RCTs, less CPAP failure, less moderate to severe nasal trauma in the nasal mask. And in 7 trials, again, reduction in failure, but also reduction in the need for surfactant and moderate to severe bronchopulmonary dysplasia. What about Biphasics Cpap? This is gaining interest, certainly in the UK. And I think what I want to emphasize to you today is the limited evidence. This is an RCT, a big RCT, of 540 infants, CPAP comparing BiPAP. And BiPAP is 2 alternating levels of CPAP, usually for 0.5 seconds at each different pressure. No significant difference in the failure rate or death, BPD, etc. In another study, however, extubation failure was commonest in the CPAP group. But I emphasized to you, this was a smaller study than the RCT, and the results were retrospective, so not the sort of evidence to place our clinical practice. What about high-flow nasal cannula? Again, something that's getting a lot of traction in the United Kingdom. This is humidified, heated oxygen or air at flow rates between 2 to 8 litres per minute by nasal cannula. A continuous positive airway pressure is generated, and it depends on the flow rate, the cannula size, and whether the mouth is closed. Interestingly, in practice, clinicians tend to favour one level of high flow compared to another. And we were interested to think, where was the evidence base? So Eleanor Jeffries, working in my group, looked at 3 flow rates, 4, 6, and 8 litres per minute. And one might imagine at the highest flow rate would be the lowest work of breathing. And we assessed the work of breathing by looking at the transcutaneous diaphragmatic EMG. These were immature infants at varying postnatal ages. What Eleanor showed was no significant differences in the diaphragm EMG, and importantly, in the number of bradycardias or desaturations. Well, what do the Cochrane reviews tell us about high flow? So this is 4 studies looking at CPAP or high flow as primary support. No significant differences in death or bronchopulmonary dysplasia. High flow was associated with a longer duration of respiratory support. And I think this reflects that then, probably as now, there is no evidence base about how to wean high flow. In a systematic review of 6 studies, 934 infants, again, no significant differences, death, BPD, reintubation, etc., but less nasal trauma in the high flow group. This is a study, a subsequent study, large study, the HIPSTER study, looking at 564 extremely low birth weight infants. Interestingly, the RCT was stopped prematurely as the interim analysis showed a difference, significant difference, in the primary outcome. Treatment failure in the first 72 hours was higher in the high flow group. In this study, which I think has got a lot of relevance to us all, is because it included infants who were in special care nurseries. Large study, 754 infants, and treatment failure again, twice as large in the high flow group. No significant differences in adverse outcomes. So the most recent meta-analysis was reported earlier this year in the Archives of Disease of Childhood. And again, higher treatment failure rate with high flow nasal cannula, although less nasal trauma. Another meta-analysis, this time in 15 studies, asked the question, could high flow, because it's perceived as a more gentle form of respiratory support, reduce bronchopulmonary dysplasia? Although 2,000 infants were included in that systematic review, there were not only no significant differences in BPD, but also none in air leak or nasal trauma. So what can we do? Perhaps SNI-PPV might reduce the work of breathing compared to high flow. And Ellie Charles, again working in my group, tested that hypothesis. The infants were studied post-extubation, 2 hours on each modality. And again, SNI-PPV showed a significantly lower work of breathing. And the reason for this was there was a lower thoraco-abdominal asynchrony. The babies on SNI-PPV breathed more regularly than on high flow. So what's the role of high flow in infants post-extubation? This was 372 infants, I beg your pardon, high flow versus not only CPAP or NIPPV. So high flow was associated with twice the extubation failure rate. So let's now move to which invasive ventilatory strategy we should be using. Largely, they're divided up into two: respiratory support working synergistically with the infant's respiratory efforts. Over the years, patient-triggered ventilation, as we call this modality, has become increasingly sophisticated. We first had assist control and SIMV, where only the beginning of inspiration triggered a pressure support. Then we had pressure support, where there was triggering at the onset, and the termination of pressure was delivered by the end of inspiration. More recently, we've had proportion assist ventilation and NAVA adjusted ventilatory assist, where the pressure absolutely mirrors throughout the baby's respiratory effort. The other large group is minimization of excessive tidal volumes, and this can be either volume-targeted ventilation or high-frequency oscillation. Now let's just walk through some of the evidence for these. A number of studies, included our own, showed physiologically PTV was associated with a lower rate of asynchrony, high tidal volumes, and improved blood gases. But in our latest meta-analysis, all we showed was assist control, or SIMV, associated with a shorter duration of ventilation, and this was in favour of ACV compared to SIMV. Interestingly, in studies that have compared SIMV or SIMV plus pressure support versus oscillation, SIMV and pressure support were associated with a greater risk of moderate to severe BPD and a longer duration of ventilation. So if we're going to use SIMV, and I hope by the end of this lecture I persuade you we shouldn't, do we use it with or without pressure support? This is Dina Patel working in my group, and what Dina showed was as you added pressure support to SIMV, you reduced the PTP, the work of breathing, because the infant is actually breathing at a lower rate. And the reason for this is during SIMV, only a certain number of breaths are supported, and actually babies do better when all breaths are supported. Now let's just move on to neurally adjusted ventilatory assist, NAVA, very sophisticated form of ventilation. The signal, the EMG signal from the diaphragm triggers the ventilator, and the pressure provided is exactly in proportion to the electrical activity of the diaphragm. In our Cochrane review, there was only one RCT, and this was a study of 60 infants, and although lower peak pressures were shown on NAVA, there were no significant differences in the duration of mechanical ventilation, BPD, or IVH rates. But with such a small sample size, it's not surprising they didn't see any differences in long-term outcomes. This is a study recently reported by Sandeep Shetty, another former MD student in my group, who is now a consultant at St George's. And he was interested with us to look at NAVA and non-invasive NAVA. And he showed, compared to conventional rates of ventilation, beg your pardon, lower extubation rates, lower duration of ventilation, and a lower length of stay. But this is in comparison to historical controls and clearly needs to be tested in an RCT. The other sophisticated form of triggered ventilation is proportional assist. And Katie Hunt, who did RMD in my group, looked at 2-hour periods of each mode in infants with evolving or established bronchopulmonary dysplasia. On both modalities, the oxygenation index improved and was significantly lower than baseline, but the AA gradient was better on NAVA, and that likely reflects the shorter triggering response time on NAVA from triggering from the diaphragm compared to PAV, where triggering is on the airway. These results are interesting, but we have to remember the NAVA electrodes are extremely expensive. Now, what about volume-targeted ventilation. Well, I show this systematic review we published in Archives because it was the first to show the volume-targeted ventilation reduced bronchopulmonary dysplasia, IVH, PVL, pneumothorax, hypercarbia, as well as days of ventilation and supplemental oxygen. But when you dig down into that systematic review, target volumes between 3 and 10 mils per kilo were used. We were interested to see what was the correct level of volume targeted. So this is again work from Dina Patel, looking at babies who are weaning from ventilation, either on assist control or SIMV. And she's looking at, again, the work of breathing. And you can see as the babies go from CMV to volume targeted, their work of breathing, regardless of mode, significantly goes up. And it's only at 6 mils per kilo is it back to baseline. Importantly, on SIMV compared to ACV, the work of breathing at each volume targeted level is significantly higher. Again, emphasizing SIMV is not good for small babies. This is work from Ollie Chowdhury, doing her MD in my group. And she's one of the people who's unusually concentrated on term-born infants. We do need more studies, including that population. Again, looking at the work of breathing, and you can see at 4 mils per kilo, it significantly goes up and only significantly lower at 6. Katie Hunt, again, looked at, volume targeted levels in infants with evolving established BPD. And as this audience knows, such babies can have marked respiratory function abnormalities. So we hypothesized, because of the low compliance, the high resistance, they would need a higher level of volume targeting. And indeed, only at 7 mils per kilo was the volume targeted, the work of breathing, significantly lower. And then just recently, Becky Lee in our group has been looking at infants with congenital diaphragmatic hernia. As you all well know, have a lesser or greater extent of pulmonary hyperplasia. We therefore hypothesized that low rather than higher tidal volumes would be beneficial. We were wrong. At 4 mils per kilo, the work of breathing was significantly higher than at 5 or 6. There was no significant difference, however, between 5 and 6 mils. Therefore, we should suggest in CDH infants, 5 mils should be used. And I just want to talk about oscillation. Because of paucity of time, I'm only going to talk about prophylactic oscillation. We all use rescue oscillation in babies with severe disease, but I will just mention to you, just look at the evidence. It's very small, and we really do need some randomized trials about how best to use rescue in what group. In this Cochrane review, prophylactic oscillation started in the first 12 hours and reduced bronchopulmonary dysplasia at 36 weeks and discharge without adverse outcomes. But this systematic review has had a lot of criticisms. Different oscillators were used, different conventional ventilators, where trials were positive for oscillation. SIMV was most frequently the comparator, and that some groups were much better at using oscillation than conventional ventilation. When the patient level meta-analysis was done, this positive benefit of oscillation was reduced. There is, however, this study, which is looking at small airway function in 2 groups of infants, one oscillated and one on conventional ventilation. And you can see at 12 months of age, the oscillation group had significantly better small airway function. Now, this was not a randomized trial, but oscillation was tended to be used in the infants who had the more severe lung disease. So this study, because it is retrospective, is hypothesis generating. And so we asked a few years back, would oscillation protect small airway function? And we assessed children who'd been entered into a neonatal trial, United Kingdom oscillation study, and were now aged 11 to 14 years. They completed a suite of respiratory health quality of life functional questionnaires, which were filled in by the children, their parents, and the teachers. And they all underwent 4 hours of comprehensive cardiopulmonary function assessment at King's College London. We had to recruit 350 infants, and I'm grateful to the parents and children who went on social media to give positive comments about the study. Now, this is a very busy slide, and it's deliberately busy because I want to show you that there are lots of significant differences here, as shown in the red. They all favour the oscillation group, who had better small airway function, our primary outcome, and better resistance at 5 Hertz, which is a non-volitional technique. This shows you the primary outcome in a different way, and you can see the red histograms all to the right. This is emphasising this is not individuals that are affected, it's a whole population effect. Now, the question everybody asked us were, are the results plausible? Is it true that something you do in the neonatal unit will still have benefit at 11 to 14 years? So Chris Harris, who did his PhD with my group, set about looking at the effect of cyclical mechanical stretch on alveolar analog cells. It's been known for some time that if you stretch these cells, they secrete interleukins. And so he developed models of conventional ventilation and oscillation and stretched the cells for 2 or 4 hours. And bigger stretch on conventional ventilation caused more IL-8 and more other interleukins, which I have not time to show you. So how does this fit in? Well, we know that hyperoxia through reactive oxygen species increases inflammatory cytokines. Our data have had it added to this side of the equation, where shear stress, prolonged cyclic stretch, increases inflammatory cytokines. This disrupts VEGF signaling, decreases angiogenesis, which reduces alveolization, altered vascular function, and impaired lung function. We've recently got the children back, well, not children now, the young adults, at 16 to 19 years, and reported the results in the New England Journal of Medicine again. Again, a very busy slide to show you, this time, no significant differences between the 2 groups. And so what we hypothesized happened that during the pubertal lung growth spurt, the conventional group caught up to the oscillation. But whether that catch-up is maintained, we will be testing by getting back these children when they're aged 20 to 25. The last thing I just want to talk about, because I think this has got huge merit, is closed-loop automated oxygen control. And we've been looking at it now for a few years. Here, closed-loop systems, and there are a variety on the market, monitor the oxygen saturations of ventilated babies, non-ventilated babies in real time and make adjustments. So Sarah Sturrock, working with us, compared 2 consecutive days, 12 hours monitoring on either closed loop or just by the nurses. And what she found was closed loop resulted in fewer short or long desaturations. The baby spent higher time in target oxygen saturation range, and there were fewer manual adjustments, which should free up nurse time to do something else. Whether this translates into better outcomes like shorter duration of ventilation, we're currently testing at King's in a randomized controlled trial. So in summary, ladies and gentlemen, high flow versus nasal CPAP is less effective as primary respiratory support. Using CPAP, we should be using nasal masks and gradually withdraw pressure. BiPAP studies are very inconclusive, and I think we do need some evidence. SNIPPV versus CPAP decreases the frequency of post-extubation failure, and we've got very little information on NIV-NAVA, and we have to remember this might be a very expensive mode. NAVA does offer advantages over other triggered modes, and I think we really need a randomized controlled trial. I've put SIMV should not be used, question mark. I honestly don't believe that. I just don't think it should be used. Volume targeting, using a level according to condition, as I've shown you, higher levels, and evolving or established BPD. Prophylactic oscillation has some long-term advantages. Whether it goes on into adulthood, we're going to be testing. I've not mentioned volume guarantee high flow because the evidence is limited, and again, something that needs further investigation. So conclusions, ladies and gentlemen, there is a wide variation in practice, and where there is a wide variation in practice, this reflects a limited evidence base, and one where we should be targeting our research activities. Promising techniques such as NAVA need to be tested in appropriately designed RCTs. And by appropriately designed, I mean they should have long-term outcomes which matter to the babies and the families. I'd like to finally finish by the funders of our studies, the MRC, NIH HDRA, Charles Wolfson, and our BRC. All the MD Res and PhD students who contributed to the many papers of the year over the years generated from King's College Hospital. And importantly, most importantly, the parents and infants who've taken part in the study. I thank you very much for your attention. Thank you. Goodbye.
This is Roger SOLL, and I'm very happy to join you to discuss surfactant replacement in term and preterm infants. My disclosures are that I am Vice President of Vermont Oxford Network and Coordinating Editor of Cochrane Neonatal, and I'll be using data from both organizations. Also, I have acted as a paid consultant for several of the major pharmaceutical companies that produce surfactant, but I have not done so for over 10 years. I have no other relevant financial issues to disclose, but I do have one more disclosure. I have tampered with the title. I don't think there's enough to discuss that is new or will impact your practice in terms of how we use surfactant in term infants. And so for the next half hour, I'll really focus on what we know and what is new in the preterm infant. If there are questions at the end and people have issues that they want to discuss about term infants, we could discuss it then. So my object of this talk is to describe the clinical impact of surfactant therapy, discuss the changes and indications for surfactant therapy in the context of less invasive respiratory support like CPAP, and appraise and gain insight into the new potential delivery methods of surfactant formulations. As the backbone of the talk, I selected the most recent guidelines that I could find on surfactant replacement therapy, and those are of the Canadian Pediatric Society. So let's follow through on their statements and recommendations, look at the evidence basis, and then discuss what is truly new and exciting in the field. So we'll start with the obvious to set the baseline issue and admit that decades of research, systematic reviews have established the unequivocal benefit of surfactant replacement therapy for neonates at risk for or having respiratory distress syndrome. Clearly, when we first began to study surfactant, there were two approaches, two strategies towards treatment. One was a prophylactic strategy in which surfactant was given at birth to infants who were at high risk of developing RDS. And the other was a treatment strategy or a selective strategy in which we gave surfactant to infants who had some evidence of established respiratory distress syndrome. As I think you know, there's a plethora of trials that address this, most of them coming from the 1990s. There are 32 trials involving 6,773 infants. These are reflected in the Cochrane database in 4 separate systematic reviews. And I think it's worth a second to review those results, in part so we can understand when we test surfactant and when we use surfactant, what are the sort of effects we hope to see for our patients, and what are the sort of effects we would see as we refine our research. So let's start with the single biggest effect of surfactant therapy. Whether we use surfactant prophylactically in babies at risk for respiratory distress syndrome, or whether we use it in so-called rescue or selective treatment, we see that it has a profound effect on reducing the risk of pneumothorax. Whether we use the earlier non-protein containing synthetic surfactants, which are no longer on the market, like ExoSurf, or animal-derived surfactants, which we still have access to, we see that there is a very large decrease in the risk of pneumothorax. This can range from a 20 to 30% risk to as much as an 80% decrease in the risk. If we look at the typical risk difference, we see it ranges from a 5% absolute difference to a 17% absolute difference. This suggests that for every 5 infants or so that we treat, maybe 6, we'll have 1 less infant with pneumothorax, a very strong result. Of course, I don't think that we would be as excited about surfactant therapy, or this would really be a topic of discussion here in the 21st century, unless it had other important effects, and it does. Surfactant replacement therapy decreases the risk of mortality, whether we use it prophylactically or use it in selective rescue treatment. This risk may be any place from a 7 to a 9% difference, suggesting that we save 1 infant's life for every 10 to 13 infants that we treat. Now, interestingly, if we look at BPD alone, we don't see a difference in surfactant replacement therapy. But if we look at the survivors who don't have BPD, or phrased here, the effect on BPD or death, we see that there is a small but meaningful reduction in the risk of BPD or death in infants who receive surfactant therapy. So these are the things we need to look for when we look at other trials to see what's the superior approach. We need to look at pneumothorax, we need to look at death, and we need to look at BPD or death. So what type of surfactant is preferable? You noted from the original trials that I showed you that are in the meta-analyses from the 1990s that there was both animal-derived products and synthetic products that did not contain protein. In part, through the 1980s and 1990s, our understanding of what the composition of pulmonary surfactant was changed. Previously, people really thought of it mostly in terms of the phospholipids it contained, which is predominantly dipalmitoyl phosphatidylcholine. But clearly there are at least 4 other surfactant proteins A, B, C, and D. Proteins A and D are very hydrophilic, and they get washed off in the process of making certainly the animal-derived surfactants. The hydrophobic proteins B and C stay with the surfactant preparations that we use and may account for much, not much, but some of the surface activity. Here in an old animal model by Bill Tooley and colleagues, they're taking a look at an animal model that either gives no treatment, the sodium chloride placebo, ExoSurf, seen in the middle pressure volume loop, or a animal-derived surfactant that is crude and washed out from the animal lung. We can see that the poor compliance, the pressure volume characteristics just with saline, are very poor, with little hysteresis, spreading of the 2 limbs, and a great deal of loss of functional residual capacity. Infants who got the synthetic surfactant ExoSurf did fare much better. But again, we're not going to focus on that today, as that is really not an available product. But take a look at the top curve, where we look at the animal-derived surfactant, and we can see that the protein-containing animal-derived surfactants really do much better in these animal models in retaining surface activity and improving lung function. So what does that mean to us clinically? There are a series of trials that early on looked at the animal-derived surfactant extracts compared to the protein-free surfactant extracts. And here, in the meta-analysis from Ardell and colleagues, we're again going to focus on where we know surfactants should impact and what the differences may be. And what we find, whether or not the animal or protein-free synthetic is given prophylactically or in treatment of established RDS, we see a large decrease in the risk of pneumothorax. The typical relative risk is 0.65. That means that there is approximately a 35% decrease in the risk, which may be as much as a 45% decrease in the risk, or as little as a 23% decrease in the risk. Those are still very large risk reductions. When we look at the risk difference, we see a point estimate of a 4% decrease in pneumothorax, suggesting that for every 25 infants we would have treated with an animal-derived product, we'd have one less pneumothorax. Again, what we really care about is mortality, and here, although less impressive, the results favor the animal-derived products. We can see that the point estimate tells us that there is an 11% decrease in the risk of death, which could be as small as only a 1% decrease in death, and a risk difference, the point estimate being 0.02. So that suggests that for every 50 babies we treat with an animal-derived surfactant, one less infant will die. Although not overwhelming statistically, given the fact that the drugs were used in the same indications at the same costs, clearly it's the animal-derived surfactants that held sway, and that's what we're using today. So in the world of animal-derived surfactants, we have various products that we can look at. We have porcine-derived products, we have bovine-derived products. We have products that are derived from lung lavage, and we have products that are derived from mincing lungs. And so there are a variety of animal-derived products to look at. Here, we're just going to focus on two of the major products available to us. One is Surfanta, a modified bovine surfactant extract, and the other is Curasurf, a porcine surfactant. And we can see here that overall, if we choose to use the porcine-based surfactant, there is an improvement in mortality prior to discharge associated with the choice of porcine surfactant. The typical relative risk suggests a 45% decrease in mortality associated with the porcine surfactants that are clinically available. There is an interesting point, though, to make, and that is that the porcine surfactants are given at twice the dose in general to the doses recommended for the bovine surfactant extracts. Here we can see in this analysis the initial dose of less than 100 milligrams, equal or less to than 100 milligrams of porcine surfactant, does not show a difference when compared to the animal-derived surfactants, whereas when given in doses over 100 milligrams per kilogram, frequently twice that amount, we do see a benefit on mortality, which makes it hard to judge whether or not, in fact, any differences we see in these products relates to phospholipid dose as opposed to something more intrinsic to the surfactant itself. So let's take a look at a question that has evolved over time in terms of our choices of surfactant therapy. As you heard, the initial treatments were either trials that used prophylaxis or trials that used selective or rescue treatment. Both were effective. But in fact, with continuing use of other modalities of stabilizing infants, the issue of which one is effective has in fact been relevant and changed over time. Initially, many of us thought that a prophylactic approach might be superior. Here's some animal work that supports that. If you give surfactant to a fluid-filled lung, which is represented on your left in figure A, that shows us a very homogeneous description of the surfactant curve. We can see that it is well distributed and evenly distributed throughout the lung. However, in the figure to the right, we can see what happens when surfactant is given after the baby has been air breathing for some period of time. And what we see is a rather helter-skelter distribution in which some alveoli might have received a great deal of surfactant, others very little, and we might have concerning ventilation perfusion mismatch. Here's another concerning animal model addressing the issue of whether or not early prophylactic surfactant might be superior. On your left is the lung of an animal that has been delivered prematurely, given surfactant immediately, and then sacrificed. And what you see here is an aerated lung that is very homogeneously aerated and without any bronchiolar injury. On your right is an animal that has been breathing air only 12 minutes. And what we see here when sacrificed is we see widespread atelectasis, and with the black arrows, you can appreciate the fact that there is evidence of bronchial necrosis. And so from a theoretical standpoint, it seems like this aggressive intubation and treatment might well be superior and needed if we want to prevent lung injury, future chronic lung disease, or other consequences of preterm birth. There is a meta-analysis and a systematic review of comparing these two approaches, prophylactic compared to selective use of surfactants, and it's interesting how the findings of this review have shifted and changed over time. The review includes 11 trials involving 4,507 infants. In the early 1990s, if we look at the trials that were done prior to the widespread use of steroids, prior to the widespread use of CPAP, we see that this clear message from these trials is that you could have very meaningful impact on outcome of these babies if you treat prophylactically. It suggests a 31% decrease in the risk of mortality that is associated with the more aggressive prophylactic therapy. What's missing is an understanding of how the context of care changes. All through the 1990s, we had an increased awareness that antenatal corticosteroids may be very important in improving lung function and decreasing death in preterm infants. Nowadays, almost 8 out of every 10 infants who potentially could benefit from steroids gets antenatal treatment. What we've understood for some time is that surfactant doesn't just cover over the issues of not giving steroids, and that steroids have their own unique benefit to the lung. So in this retrospective analysis, in which infants were only randomized to surfactant, but this represents whether or not they also got steroids, we can see that mortality is greatest here on the right, where neither surfactant nor steroids were given. Interestingly, whether you got surfactant and didn't get steroids, or didn't get surfactant and got steroids, you have a very similar outcome regarding death. But if you got both, you have a remarkably lower risk of dying, suggesting that there is synergy in these treatments and not just choosing one or the other as your approach to management. Add to that changes in our use of non-invasive ventilation. Here, quoting the classic Avery study from 1987, showing how the group in Columbia in New York City had shockingly lower rates of what was then defined as BPD at 28 days, compared to other very high-level centers that were part of the SCORE grant. This has led to more and more use of stabilization on CPAP. And so now we have two major trends from the 1990s into this century of stabilizing infants more on CPAP and giving more mothers antenatal steroids. So that brings up the question, what do the more recent trials of delivery room management of prophylaxis versus selective care tell us? And there are at least 4 major trials that begin to address this issue. There are the SOPORTE trial from the NIH and the Dunn trial from the Vermont-Oxford Network. Both of these studies enrolled infants less than 30 weeks, the SOPORTE trial 24 to 28 weeks, the Dunn trial around 26 to 30 weeks. In these trials, infants received CPAP stabilization or early surfactant. In the Dunn trial, there's also a group that received what would conventionally be called INSURE, but for the purpose of this study was called ISX. These trials enrolled all comers and therefore are included in my discussion. These other 2 trials, Coyne and Sandry, enrolled infants with some minimal respiratory disease and were not strictly prophylaxis, but they do help support our thought process around what approach is best. Looking strictly at the studies that took on all comers, the SOPORTE trial and the VON trial, we can see that when we look at neonatal mortality, in fact, the trend there is in a very different direction than the trend when we look at the studies from the early 90s. So if we only look at the early 90s, there's a very profound effect on mortality associated with prophylactic care. If we look at the more recent trials, we see a message heading in the other direction. And when we synthesize all of the trials, we no longer see a benefit associated with prophylactic surfactant administration. In fact, if we look at BPD or death in the recent trials, we see a small but meaningful improvement in results regarding a decreased risk of BPD or death associated with the more patient selective approach that includes giving antenatal steroids and stabilization on CPAP. And so in many ways, this question has turned, and best practice today, based on these reviews, really is the more patient approach to care. So then the question, if we really are going to use CPAP first, when or how should we give surfactant to these infants? In our Vermont-Oxford Network trial, we compared true prophylactic surfactant to what we called ISX, essentially INSURE, intubation, surfactant, and extubation, to more patient care of stabilizing infants on CPAP and only treating if they met a criteria. And here you can see that the loser in this proposition is the more aggressive care of intubation and prophylactic surfactant, and that both INSURE and a more patient approach to CPAP and selective care seem quite similar. There is a meta-analysis that has taken a look at INSURE versus just CPAP and selective treatment. 9 studies involving 1,551 infants are included. And what we see here is that there isn't a great benefit from being more aggressive with INSURE than there is just with the more patient CPAP and selective treatment approach. Although we see a point estimate that suggests there might be a small decrease in air leak, chronic lung disease, or chronic lung disease or death, only for air leak do we see any significant improvement. So let's get to the fun and new stuff regarding surfactant therapy. The newer techniques of surfactant administration, which I think have everyone wondering whether or not these are ready for prime time in our practice. And I'll touch mostly on thin catheter administration, but briefly address both laryngeal mask airway administration and aerosolization or nebulization. So here is the randomized trial of laryngeal mask airways compared to endotracheal intubation for surfactant delivery of Piñaro and colleagues. They looked at moderately preterm infants, so infants who were spontaneously breathing and diagnosed with RDS and stabilized on nasal CPAP with an FiO2 of anything from 30% to 60%. And between 3 and 48 hours of age, they were randomized either to the endotracheal tube group who were intubated or the laryngeal mask airway group who received surfactant via that route. What they found was incredibly interesting. They found that the more aggressive, not aggressive, but the less invasive use of laryngeal mask airway was associated with a decreased need for mechanical ventilation, shown on the right. So what about this issue of thin catheter administration? There are many techniques that have been tested. The Cologne method, the Hobart method, the Take Care method, the Karolinska method, all of them involve using a catheter that cannot be used for delivering positive pressure to deliver the surfactant. And they involve infants who either are maintained on CPAP or at least spontaneously breathing and giving the surfactant through this thin catheter. Although the techniques are different, they have that one similar property that they are incapable of giving positive pressure, so the baby needs to be spontaneously breathing and otherwise stable. Now, when it comes to this method, there have been two approaches in the trials, which I've pictured here in these figures. The first approach is to say, well, let's wait until the babies are sick enough where we're going to consider surfactant, and at that moment, compare these two less invasive approaches. So should we do thin catheter administration, or should we use an endotracheal tube and deliver in-shore and rapidly extubate the infants? The other approach, which in some ways interests me more, is the strategic approach. And that is saying, well, we have the thin catheter, we can sort of sneak it in earlier, or we can wait and give it selectively. So it's in some ways both a thin catheter versus other surfactant administration techniques, but also the degree of severity. Can we effectively treat earlier with the thin catheter and get even more advantages? I'm sure you're all aware of perhaps the most recent trial on this issue, the Optimist Trial, which used more of a strategic approach than a head-to-head approach. It was a multi-center trial involving infants 25 to 28 weeks gestation. The infants were eligible if managed on CPAP and requiring an FiO2 of greater than or equal to 30% at less than or equal to 6 hours of age. Infants were randomized to receive 200 milligrams per kilogram of poractid alpha via either the Hobart method, which involves using a small angiocath, or sham treatment. In both groups, infants remained on CPAP unless they met intubation criteria, which, and although this could be debated what the right criteria are, in this study was an FiO2 of greater than or equal to 45%. The primary outcome was the composite of death or physiologic BPD. And what we see here is that although the point estimate suggested a potential difference in the risk of death or BPD, that in fact it did not meet statistical significance. There was no difference in death, and there is a small but meaningful difference in the risk of BPD in survivors at 36 weeks gestation. In addition, there was some small advantage regarding pneumothorax that was shown here, though, as I mentioned before, no difference in death. So let's take a look at what this new information does in the context of the older information. And let's do a back of the envelope calculation by taking the published review of Abdel Latif in the Cochrane Library and adding the Optimist Trial to it. What we see is really quite interesting. First of all, most of the trials, I think you can see here, were done in that head-to-head comparison, looking at thin catheter administration versus in-shore at the same moment of disease severity. And interestingly, it's quite effective head-to-head. It decreases the risk here of the need for intubation within 72 hours by approximately 39%. That's a risk difference of, the point estimate is minus 12%, suggesting that perhaps for every 8 or 9 babies that we choose to treat with a thin catheter instead of treating by insure, that will have one fewer infant who needs intubation afterwards. The trials that are more strategic, and by that I mean both used a thin catheter and treated on a earlier, less severe criteria, show more effect in this. A 30% absolute risk difference in the need for intubation within 72 hours, suggesting that for every 3 or 4 babies that we treat, we'll have 1 fewer infants who need to be intubated in the first 3 days. Again, that's nice, but what's really important is looking at some of the downstream clinical outcomes, and they are surprisingly strong, given what appears on the one hand to be a small change in administrative technique. What we see in terms of death or BPD in the infants who are treated head-to-head is that we see a 48% decrease in death or BPD, a point estimate of around 11%, which could be as much as a 16% or 7%, very high for the magnitude of the effect. And with the more strategic approach, we also see a decrease in the risk of BPD or death, suggesting that for every 10 infants that we treat, we will have 1 fewer case of death or BPD. You might ask, why would that be? These are relatively small techniques. And I think, speculation, that part of it is that whenever we have a tube that we give positive pressure through, we cause some damage. And the idea that these infants are left breathing spontaneously without our administration of positive pressure seems to have meaningful downstream effects. So let's discuss the very, very least invasive approach, sort of the holy grail of surfactant administration, and that is nebulized or aerosolized surfactant. And first, I think we need to admit to ourselves that it's not so easy to intubate a preterm infant. In this work by Sawyer and colleagues, when they reviewed over 2,000 tracheal intubations, 14% meant the definition of a difficult intubation. That means defined as one requiring 3 or more attempts by a non-resident, so not in a teaching situation, provider. And these, of course, were most common in the smallest babies, less than 32 weeks or less than 1,500 grams. So this entire idea that surfactant is dependent on intubation, which in and of itself is a difficult task, really makes us think, boy, I wish we had a better approach. And this approach has been studied in several small trials, but this is probably the largest trial to date which has been done using this approach. This trial involves well over 500 infants and had the following approach. It was a prospective randomized unblinded trial. They used InfraSurf, which is a bovine-derived surfactant, in infants who were having some signs of RDS. RDS was not specifically defined based on X-ray. It really is more that they had RD than RDS, respiratory distress, not necessarily what we might classify as respiratory distress syndrome. Calfactant was aerosolized at around 210 milligrams of phospholipid per kilogram and delivered directly into the mouth. Infants in the aerosol group received up to 3 treatments, at least 4 hours apart. The control group received usual care. 22 NICUs enrolled over 450 infants. In this trial, the percentage of infants who received aerosolized calfactant who required intubation was significantly lower than those that got usual care. And if intubated, they're intubated at an older age. There was an unfortunate slight increase in the risk of pneumothorax, which, sorry, I misspoke. There's an increase in any air leak, but in fact, in the risk of pneumothorax is slightly decreased in the aerosolized group, in keeping with our thinkings about how surfactant might work. This seems very promising at first blush, but I would point you towards a commentary that was published with this by Glaser and Wright, which I think points out some of the deficiencies in this evidence. Glaser and Wright state, this result is promising and in accordance with previous pilot studies and a recent phase 1 clinical study documenting feasibility and safety of aerosolized surfactants. But despite these promising results, the study design potentially introduced significant bias. Most notably, there was no criteria for surfactant therapy in the randomly assigned groups. And so here's the thought I'd like to leave you with regarding these studies. There are pragmatic trials like this one and explanatory trials. Pragmatic trials seek answers to whether an intervention will work under usual conditions, whereas explanatory trials are best suited to test causal hypotheses in settings where confounders can be minimized to the greatest possible degree. We tend to think of using pragmatic trials when there is more evidence of efficacy, but we do not know how generalizable it is or the exact population to use it, etc. And explanatory trials where we protocolize more of the tests, refine the population, and wind up at the end of it believing that we've either proven something to be efficacious or not. One could state that to say that explanatory trials give us some idea of efficacy, whether the therapy works, and the pragmatic trials give us effectiveness, more like will it work for me in my general conditions. And so the problems here are the following. The study population is very broad and poorly defined. The methodologic rigor in that without protocolizing interventions, etc., is poor. And the clinical endpoints that they used are not the endpoints like BPD, etc., because in fact the population was somewhat older and larger, and may lack meaning in terms of whether or not we've established efficacy of these practices. So to sum up, what to actually do? Well, it's good to refer to the Canadian Pediatric Society recommendations, and they're pretty clear. Use CPAP to stabilize preterm infants. Make sure that you have given the mothers who are eligible corticosteroids. CPAP should be provided early on from birth, and early surfactant should be provided for newborns with increasing severity of RDS. Infants, they state, whose oxygen requirements exceed an FiO2 of 50% should receive surfactant replacement. I think that in fact it is somewhat debatable regarding what that cut point should be. At my own institution, we use a somewhat lower cut point, around 40%. And they strongly consider whether or not newer methods of surfactant administration, such as LISA, less invasive surfactant administration, or MIST, minimally invasive surfactant therapy, are the appropriate approach. So I'll stop here and open the discussion up for questions. Thank you very much.
Hello, and welcome to this presentation on volume guarantee in both high frequency and conventional ventilation. My name is Martin Kessler, and I've had the privilege of addressing this meeting a number of years ago in person in Buenos Aires, and I greatly enjoyed that. So I'd like to thank the organizers for inviting me once more to address you, albeit virtually, which is not nearly as enjoyable, but we'll have to make do. So since time is limited and without further ado, we'll jump right in and talk about what we need to talk about. Let me move this out of the way and jump to the first slide. There we go. So let's begin by talking about why volume targeted ventilation is important. I will show you some evidence, which you hopefully already know, that pressure is not the main culprit, but rather excessive tissue stretch. You know that inadvertent hyperventilation is common, and that hypocapnia is bad for the brain and also for the lungs. And I will show you why adult type of volume controlled ventilation doesn't work very well in neonates. So here is an example of a number of studies that show the same thing. And in this particular instance, investigators studied two groups of small animals. In one group with healthy lungs, the lungs were free to expand. In the open bars and the closed bars are animals who had a plaster cast applied to the chest and abdomen to restrict chest wall excursion and limit tidal volume to normal physiologic value. And what you see here is that when looking at the capillary filtration coefficient, a measure of acute lung injury, at 15 centimeters of inflation pressure, there was really no change. At 30 centimeters, which is already too much pressure for healthy lungs, there was a significant increase in capillary filtration coefficient, but no change where the lung volume, lung excursion was constrained. No surprise that at 45 centimeters of pressure, there was a great increase in acute lung injury markers. But what is surprising is that despite that high pressure, when lung excursion was limited to normal physiologic tidal volume, there was no increase in markers of acute lung injury. So the conclusion is that pressure without causing a correspondingly large increase in tidal volume is not in itself injurious, and that even modest pressure, if it's excessive given the lung compliance, can injure the lungs. So volume controlled ventilation, of course, has been standard of care in adult and pediatric ICUs because of the importance of maintaining a stable minute ventilation. The problem with volume controlled ventilation is that what's controlled is the tidal volume delivered into the ventilator circuit at the proximal end. And that's not a big problem when there's a large patient. There will always be some loss of volume to compression of gas within the tubing, stretching of the tubing, with and of course compression within the humidifier as well. But in neonates with uncuffed endotracheal tubes, we also have variable loss of tidal volume to endotracheal tube leak. And as a consequence, the amount of gas that actually enters the patient's lungs is only very loosely related to the set tidal volume, especially when the lungs are very small relative to the volume and compliance of this circuit. So for that reason, we all adopted pressure-controlled ventilation and have used it for many years. Pressure-controlled ventilation in its basic functionality is nothing more than a mechanical T-piece resuscitator, which you all use. And so during the expiratory phase, there is flow of gas in the circuit. There's a PEEP valve maintaining certain descending pressure. And in SIV mode, the patient can breathe in and out of the circuit. And then when the ventilator cycles on, the expiratory valve closes, the circuit's pressurized, and gas enters the lungs in proportion to the pressure within the circuit and the compliance of the lungs. And we don't worry about a leak around the endotracheal tube because there's plenty of fresh gas available to compensate. And so the ease with which we could ventilate babies despite a large leak around the endotracheal tube, plus preoccupation with the conviction that pressure is the dangerous parameter, led to the widespread adoption of pressure-controlled ventilation. But the problem with pressure-controlled ventilation is that as compliance of the lungs changes, which it can quite rapidly, at least early on, the tidal volume that's delivered and minute ventilation that's delivered can increase dramatically, leading to lung injury and brain injury due to hypocapnia. So along came volume-targeted ventilation, which is not the same thing as volume-controlled ventilation. Volume-targeted ventilation, as I use the term, is pressure-controlled ventilation with volume targeting, which occurs by automatic adjustment of inflation pressure in order to maintain a stable tidal volume. So as opposed to making those changes manually, the ventilator makes these automatically and in real time, leading to more rapid weaning from mechanical ventilation and avoidance of lung injury. The waveform of volume-targeted ventilation is that of pressure-controlled ventilation. What is different is the automatic adjustment up and down of the pressure. But as again, with pressure-controlled ventilation, when the circuit's pressurized, seen here, flow begins, reaches a peak, and then declines. So gas enters the lungs relatively early in the respiratory cycle. With volume-controlled ventilation, there's continuous flow of gas into the circuit until the set tidal volume is delivered. It's sometimes steady, sometimes it's decelerating, but the lungs only fill at the very end of the inspiratory phase. Pressure rises passively and is a secondary or derived variable. The basic way that the algorithm works is there's an initial tidal volume generated with whatever pressure is initially used. The tidal volume that results is measured, apologies, and compared to the target tidal volume. And depending on whether the tidal volume that is measured is less than, equal to, or greater than target, the inflation pressure will be adjusted up or down or remain the same for the next cycle. So it's always looking back at the previous cycle, which is fine. It may take several cycles if there's a large change in compliance or change in patient's respiratory effort. And we'll talk about that a bit more later. So we have lots of good evidence that volume targeting is important. The latest meta-analysis was published now 4 or 5 years ago, showing significant improvement in most of the important outcomes. There was not a statistically significant difference in the combined outcome death of BPD, although the point estimate suggested a 25% reduction. There was a significant reduction in severe BPD. Here's the point estimate with the confidence interval seen here, and a number needed to treat of 8, which is a very, very impressive number. Severe intraventricular hemorrhage, peroventral leukomalacia, about 50% reduction in both of these. Here are the confidence intervals again, not crossing 1, therefore statistically significant. Pneumothorax was reduced by 50%. Number needed to treat is a little higher because it's a less common event. But hypocapnia was also reduced by about 50% with the number needed to treat of only 3 because hypocapnia is so common. And duration of mechanical ventilation was shorter. This meta-analysis included almost 1,000 babies, so this is fairly impressive data. It is a combination of different modalities of volume targeting. It's also important to make sure that whatever tidal volume we carefully control is distributed evenly without into a well-aerated open lung. We've talked about that many times before. So let's talk briefly about some practical aspects and guidelines, and then we'll switch over and talk about the more exciting stuff, which is high frequency volume guarantee. But with conventional ventilation, I argue we should start immediately upon initiation of ventilation because that's when lung compliance changes most rapidly, when we give surfactant, when we help recruit lung volume, which improves compliance, and when the baby clears their lung fluid soon after birth. The tidal volume target is the most important decision, and one size does not fit all. For your typical preterm infant in the first days of life, 4 to 5 ml per kilo measured at the airway opening is the right tidal volume as a starting point. Adjustments may be needed later, but different starting tidal volumes are indicated in different diseases or different size infants. Really small babies need a bigger tidal volume, and I'll show you why. Infants with Mercurial Aspiration also need a bigger tidal volume for different reasons. And older infants with chronic lung disease also need sometimes much higher tidal volume. We and others have shown that it works better when applied with modalities that support every spontaneous breath. SIMV, only the SIMV cycles are subjected to volume targeting. And if you're not supplying sufficient pressure support, you may need a larger tidal volume. You want to keep your pressure, your inflation pressure limit relatively tight to the actual tidal volume that's needed. And you need to, of course, keep track of not just what the pressure limit is up to which the adjustment can occur, but also what is actually being used. And of course, we want this to take advantage of the self-weaning ability of volume-targeted ventilation. One of the advantages of volume-targeted ventilation is you need fewer blood gases, and weaning occurs in real time. The machine doesn't wait for morning rounds. It doesn't wait for the next blood gas, it weans you in real time, which is why more rapid weaning occurs. So having considered the underlying disease process and the size of the baby, you choose appropriate ventilator settings. And that's where most people leave it, but actually the important thing is the next step, which is to evaluate the patient's clinical response and pulmonary graphics before you even get the next blood gas. Blood gas should only confirm the correctness of your settings. It should not there should not be any big surprises on your blood gas, because you have looked at the patient and you have evaluated how they agree or not with the settings that you chose for this patient, because then the starting points are just averages, and some babies will need more and some babies will need less, and the baby will tell you. What can the baby tell us? Well, if we understand what they're trying to tell us, for example, if a baby stopped breathing, baby who had been breathing nicely, after 10 minutes after intubation, baby stops breathing, perhaps this is telling us that we are overventilating. We took away the baby's respiratory effort. If the baby becomes or remains tachypneic with retractions, the baby is clearly telling us that the support is inadequate to meet his or her need, and we need to reevaluate. If the baby's oxygen requirement is rising rather than dropping, that suggests that we have inadequate mean airway pressure. We've not achieved adequate lung recruitment. We've not achieved the open lung. And my favorite, the baby is fighting the ventilator. And the blood gas is bad, people say, because the baby is fighting the ventilator. But in reality, what it suggests is that the baby is air hungry, that the support is inadequate, and the baby is struggling to breathe. There may be many reasons. Maybe the endotracheal tube is partially obstructed, it's kinked, it's sitting on the carina, it's in the right mainstem bronchus, who knows, maybe the pressures are inadequate, but it is up to us to figure out the reason, but the baby is telling us something. And just giving drugs to knock the baby's effort away is not the right response. What about looking at the graphics? Well, if the baby is agitated, it's hard to interpret the graphics, so we may need to improve the support so we can even see what's going on. But if we know what to look for, there can be some very useful information. Obviously, it can tell us about the appropriateness of inspiratory and expiratory time. It can tell us about the tidal volume. Are we reaching the tidal volume that we hope to reach? Is it too much? Is it too little? What is the pressure that we are seeing in volume guarantee? Is it hitting the limit? Is it very low? Is there high airway resistance and other issues? So it's important to understand the interaction between the actively breathing baby and the ventilator, because it turns out, of course, we are supporting, not taking over the baby's respiratory support. And the tidal volume that enters the lungs is the result of the combined transpulmonary pressure, which consists of the positive pressure from the ventilator here in green and the negative inspiratory effort of the baby depicted in red. This patient contribution can be quite inconsistent, highly variable, occasionally absent, and that's always perturbing the equilibrium and causing fluctuations in tidal volume. And that is something we need to be aware of. We don't see the patient's respiratory effort, and it is not measured, it is not included in the lung mechanics display that the ventilator shows us. Somehow we jumped a couple of slides. So on the ventilator display, you typically see three waveforms: the pressure, flow, and volume. Goodness. What you don't see, but I drew in here in red by hand, is the patient's negative inspiratory pressure. So positive pressure from the ventilator, negative pressure from the baby. You can see that the pressure from the ventilator is constant, but the effort of the baby is intermittent and highly variable. And for that reason, the flow and volume are also variable. And that's okay. with pressure controlled ventilation, you will see quite a bit of fluctuation in tidal volume. With volume guarantee, if the tidal volume is excessive, as for example, maybe here, the pressure generated by the ventilator will come down. And if the tidal volume is consistently greater than what we have set, if the baby is working hard, is generating a bigger tidal volume than what we've set, you might see this. And this is an example of a baby who is breathing vigorously, is generating a tidal volume that is larger than what is set. It's not shown here, but it is. And that's why the ventilator progressively lowered the inflation pressure it is generating, as it is programmed to do when the tidal volume exceeds the target, until the baby is getting essentially no support and is on endotracheal tube CPAP, and that's not a good thing. So this is to be avoided, but this is information. You need to see this and understand what's going on. Let's briefly talk about leak compensation, because leak around the endotracheal tube is another concern why some people are hesitant to use volume targeted ventilation in neonates. But the Draeger ventilator, the VN500 and the more recent 600 and 800 iterations have a very effective leak compensation algorithm. I won't go into the details, but for example here, if we have a 6 ml tidal volume going in and there is a large enough leak, most of the leak is during the inspiratory phase. So let's say 2 ml or a third of the tidal volume disappears due to leak around the endotracheal tube, and only 4 ml enters the patient's lungs. This is not measured directly, but the Draeger ventilator can calculate this. There's usually also some leak during the expiratory phase, let's say 1 ml, it's typically less, so that the exhaled tidal volume might only be 3 ml. And if you're using that 3 ml in the absence of leak compensation on many other devices, then you would be underestimating what the patient's actually seeing. So a large leak around the endotracheal tube used to be a contraindication to volume guarantee, but it is no longer with the modern device, with the VN500 and later, because this really effective leak compensation maintains a constant tidal volume despite progressively larger leak. And you can see that here on an older study that basically tested this hypothesis. So we have here on the horizontal axis progressively larger leak going up to 60–80% and beyond. And the measured inspiratory tidal volume, of course, progressively deviates from the actual tidal volume of 4 ml, going way up when you exceed 80%. The exhaled tidal volume deviates less. In this study, they used rather low end expiratory pressure. The higher the PEEP, the more leak you're going to see during the expiratory phase. What you can see here is the corrected or calculated tidal volume, which remains remarkably stable despite leak between 60 and 80%. So this works really well, and there's really no more of a concern as long as you're using the leak compensation. So let's briefly talk about why I suggest using a larger tidal volume in the really, really small babies. So we, a number of years ago, looked at what tidal volume was being used when there was a blood gas with a PCO2 in a normal range. And it was in the babies, these were all babies less than 800 grams. And at the upper end of that range, the tidal volume needed for eucapnia was about 4.5 to 5 ml, as was shown by others. But at the other extreme, what I call ridiculously low birth weight infants, down around 400 or 500 grams, you need a larger tidal volume. And this has to do with the fact that the dead space of the flow sensor is fixed, and it's the same whether the baby is 800 grams or 400 grams, but it becomes proportionately larger, obviously, in the 400 gram baby, and therefore some compensation is needed, and tidal volume typically needs to be about 6 ml per kilo, not 4.5 or 5. Otherwise, we'll undersupport that baby. Different disease process, Mercurial aspiration, where there's typically a lot of air trapping, overexpansion, heterogeneous inflation, and that translates into increased physiologic dead space or wasted ventilation. We similarly looked at what tidal volume was needed for eucapnia in a bunch of babies with classic Mercurial aspiration compared to controls with more homogeneous disease, but similar birth weight. And what we saw was a substantially larger tidal volume in the Mercurial aspiration babies as we anticipated, a highly significant difference. They were also more tachypnic, so their minute ventilation was more than 40% higher than in the control patients, yet their PCO2 was virtually identical, which tells us that alveolar minute ventilation was in fact the same. It was all due to increased physiologic dead space, so pathophysiology matters. And finally, with increased postnatal age, we looked at those babies less than 800 grams longitudinally, and what we saw was that they required progressively larger tidal volume despite allowing for permissive hypercapnia. And this again reflects evolution of the lung disease process with tendency to have some air trapping over expansion and probably also increasing alveolar anatomical dead space. And taking this further out, babies who are 2 or 3 or 4 months old with really severe BPD, they often need tidal volumes as large as 8 or 10 ml per kilo and occasionally more. So it's important to understand that one size does not fit all, that we have to really think about who we're supporting. And we need to look at the baby and see if they agree, if they're comfortable with the settings that we chose. Weaning, of course, occurs largely by itself as long as we have appropriate tidal volume that is not too low and not too high. We want the baby to have a respiratory drive, so pH should be less than 7.4, but it should not necessarily be very low because if we turn the tidal volume down too much, the baby will be struggling and will be bringing that pressure down to nothing. And that will, of course, result in distress, rising oxygen requirement, increased oxygen consumption, and potentially atelectasis, setting up the baby for failure. Do not continue to lower the tidal volume as long as the baby has a respiratory drive. And most babies can be extubated when they're comfortable with low levels of positive pressure. And so this will conclude the portion with conventional ventilation. I went rather quickly because I wanted to spend some time on the high frequency. If you want to read more about this, there's a review paper that I wrote a couple of years ago. And there is a new edition of the assisted ventilation of the neonate that's just coming out. So you can read about all sorts of respiratory support. All right, moving to high frequency combined with volume guarantee. Well, the SensorMedics can't do that. The SensorMedics, unfortunately, is still the only high frequency device available in the United States. It is an antique. It hasn't changed in its basic functionality since the 1980s. It's bulky, it's noisy. It's got that stiff short patient circuit, so kangaroo care is problematic. It can't do anything other than high frequency, can't measure tidal volume, doesn't give you any waveforms, doesn't store any data. Of course, there are other ventilators out there that have high frequency capability. They're available everywhere except in the United States. You have that capability most likely where you live, and you may be using it as we speak. But for us, it was still not available, still isn't. So we were very interested in bringing that technology into the United States. So we did a study, which I'll tell you about briefly in a moment. So the Babylog VN500 and its newer iterations, of course, can do both high frequency and conventional. It's a real oscillator. It gives you perfect sinusoidal waveform at 1:1 ratio. It can go from 1:1 to 1:3. It uses this low compliance conventional ventilator circuit. It's much quieter than the SensorMedics. And it, of course, measures tidal volume and a measure of CO2 elimination. And what really turns me on is can do volume guarantee. Why is it important to be able to use volume guarantee with high frequency? You remember that CO2 elimination with conventional ventilation is proportional to frequency or rate and tidal volume. With high frequency, it is frequency and tidal volume squared. So that tidal volume is a much more important factor, and even small changes in tidal volume can readily alter CO2 quite dramatically, and there's a real danger of hyperventilation, and that's been shown in a number of different studies. So that's some art in there. How does it work? Well, for those of you not familiar with it, it really works rather like conventional volume guarantee. In conventional, it's the PIP that's adjusted. In HFOV, of course, it is the amplitude that is adjusted. So again, the tidal volume is measured. It's averaged over 10 seconds or so. It's compared to the target tidal volume, and the amplitude is then adjusted up or down to maintain the set tidal volume. The amplitude limit, just like the pressure limit with conventional, has to be set, typically about 5 centimeters above the current value, maybe 10 in some instances where there's more variability. And just like with conventional, there's an alarm. And you have to remember that your mean airway pressure, your other control with high frequency, is still on manual control. But amplitude, which controls CO2, is automated. You all know, all of you who use oscillatory ventilation know that tidal volume delivery is frequency dependent. And at lower frequencies, for any amplitude setting, you get a bigger tidal volume than at higher frequencies. Well, with volume guarantee turned on in this study, you can see that something very different occurs. Now the tidal volume stays the same until very high frequencies are reached, and there may be a little bit of tailing off at these really high. This was at maximum amplitude. These are really high tidal volumes for high frequency. Typically, we're using around 2. But this just illustrates the point, right? So very different. You have to remember that now it'll be different. Changes in frequency will not change your tidal volume. And therefore, frequency has the usual effect on CO2 elimination, namely increasing frequency increases CO2 elimination, just like with conventional ventilation. And unlike with high frequency ventilation, with high frequency ventilation, the effect on of frequency on tidal volume overrides the effect of frequency on tidal volume. So just remember that it behaves more like conventional ventilation in terms of rate. Higher rate increases CO2 elimination. Very interesting. Well, what's the right tidal volume? So there have been some older studies that looked at tidal volume with measuring in a freestanding hot wire anemometer, and the numbers were typically somewhere in the between 2 and 2.5, with a pretty wide range of observations. Another study more recently also showing tidal volume of about 2.5 ml per kilo, with again a significant standard deviation, which tell us once more that one size does not fit all. And it turns out that the same variables that affect need for tidal volume in conventional ventilation also apply in high frequency. I won't have time to give you all the details, but here are some data from a colleague in Japan who collected these data for me in preparation for launching our study that I'll tell you about in a moment. And what you see is a similar relationship, an inverse relationship between birth weight and tidal volume needed for normal capnia. So they use the frequency of 15 hertz, so the tidal volumes are a little bit lower, but in the really, really small babies, larger tidal volume was needed than in the larger babies. You can see that here in more categorical depiction, but the same message. Tiny babies, bigger tidal volume is needed because of the dead space. Dead space matters, dead space is real. So in order to get approval in the United States, we pulled together essentially a who is who in high frequency ventilation in the United States. I had the privilege of running that study, and the goal was to allow high frequency ventilation to occur in the with volume guarantee to occur on the Draeger ventilator in the United States. This was primarily focused on pleasing the Food and Drug Administration to get their approval. So this was not a randomized study as we had originally hoped to do, but the primary goal was safety. We prospectively collected some historical controls relatively recently from 9 centers. That was the comparison arm, and we enrolled 225 babies prospectively. It took us 3.5 years. But we got it done. Again, the inclusion criteria are pretty standard, very small babies. They need to be early in their career. and they needed to require respiratory, intubated respiratory support, and they needed to be sick enough in most instances to benefit from oscillatory ventilation. So I think I skipped the slide. There we go. The basic demographics were not very different. Oops. My computer runs away with me. So they were small babies, a little bit smaller, but not significantly different in the prospective study. Similar gestational age, although proportionately they were more on the extremely low end of the gestational age, meaning more at risk for severe complications. No other substantial differences. So as I said, the primary outcome of interest was safety. Death was not different, not surprising. Mild IVH, slightly lower. Severe IVH was trending lower. It was not statistically significantly lower, but the goal was to show that it's equally safe, and it certainly was. PVL, again, not statistically significant, but trending lower. So these are all benefits you would expect, knowing what we know about volume guarantee with conventional ventilation. Here are some trends of PCO2 over the first 48 hours. PCO2 is quite stable. The standard deviations are in dashed lines, relatively tight. It's working quite nicely. The tidal volume, and we use 10 Hertz frequency for various reasons, was in the range as we expected it to be. And there was the typical relationship as was shown with conventional and as was shown with I'm sorry, with the preliminary data from Japan, where my computer is jumping all over, where there was this inverse relationship with the smallest babies needing a larger tidal volume compared to the larger infants, and that was a statistically significant relationship. And finally, I want to show you how reliably the tidal volume was actually met. So 93% of the time, the tidal volume that was measured was within 0.1 ml of the set tidal volume. A few times it was below. Some of those times it was because the pressure amplitude limit was not appropriately adjusted. So when we excluded those situations where it was user error limiting tidal volume delivery, the accuracy was 96%, which is really quite remarkable. Plus or minus 0.1 ml. So we found that the device really worked exactly as intended with very good reliability, ease of use. This was everybody's initial experience with the device, and yet there were very few significant problems. There were no safety concerns. PCO2 was remarkably stable. And clearly eliminating the risk of hypocapnia with volume guarantee attached to high frequency ventilation is really going to make me be much more willing to start using oscillatory ventilation in the highest risk babies as a first-line therapy. And hopefully we can get this approved sooner rather than later. So thank you very much. I went a little bit over time. Hopefully we have some time for a live question session. Thank you very much for your attention.
Hola a todos, vamos a dar comienzo al panel de debate. Quiero agradecer especialmente a nuestros tres disertantes por sus excelentes presentaciones. Nosotros también tenemos muy buenos recuerdos de su pasaje por acá, por Buenos Aires, por nuestros simposios en los años anteriores, y la verdad que estamos muy agradecidos de su nueva participación. Contamos en el panel reactivo con la doctora Patricia Bellani, que es jefa clínica del área de neonatología del Hospital Garrahan, y con la doctora Daniela Satragno, jefa del servicio de neonatología del Hospital Ricardo Gutiérrez. Antes de iniciar, digamos, las preguntas del público y del panel, quisiera preguntarle a la doctora GREENOUGH, aquí también en Argentina la cánula de alto flujo ha tenido un crecimiento importante. Siempre nos preguntamos, y quisiera que nos hiciera un comentario sobre la presión que se genera con ese tipo de dispositivo, y en lo particular creemos que quizás es un dispositivo que si bien ella ha mostrado que no presenta demasiadas diferencias con el resto en cuanto a beneficios, quizás pacientes displásicos con una edad postconcepcional mayor quizás tiene una posibilidad, y no sé si es el uso que le dan en su servicio.
Sure. Thank you very much for that. Those very important questions. The pressure, I mean, is generated, but it's dependent on the size of the cannula, the flow rate, whether the baby has their mouth open. So I think, you know, we have to take all that into consideration. I mean, although randomized trials have not showed significant benefits in certain populations, there is no doubt that the babies are easier to look after on high flow. It's very popular with our nursing staff. And I think in babies that are weaning off oxygen, etc., it's a very good modality to use to step them down from CPAP. And then, I think you think a BPD baby, I think that's where you're wanting to give more family-centered care. It's much easier to look after the parents cuddle the baby on high flow than keeping the baby on CPAP.
Una pregunta para Roger, si puede decirnos, digamos, si la implementación de estos métodos mínimamente invasivos requieren la capacitación previa, el ensayo previo para todo el equipo que interviene en la asistencia de estos bebés, y si eso, digamos, lo han realizado en los servicios que él conoce, de cuánto tiempo estamos hablando, o si uno puede rápidamente implementar, considerando que la mayoría de los neonatólogos entrenados son capaces de hacer la visualización.
A wonderful question. And it goes to the core of, first, do you believe the trials have shown efficacy? Did they work in the rigid structure of the trial itself? And I would argue, yes, they have demonstrated efficacy. But your question asks us, what about effectiveness? How am I going to do this with my staff? And I agree with, I think, the direction your question is taking, which is some training will be necessary if you decide that this approach holds some real benefit for your infants. For the trials, and even though they all used slightly different methods of inserting a thin catheter, some in Europe used a McGill forceps, others, such as the Australian group, just used a angiocath and directly visualized and placed it. It would all require some training and perhaps even some embellishment. I don't know if you have video guided intubation techniques and tools, but I take your point that if you think this is efficacious, if you believe it worked in the trials, there still is an important step to look at your staff and your decisions about how you're going to deliver thin catheter surfactant to infants.
There's actually a trial going on in the United States to validate thin catheter administration compared to standard methodology. So we'll have actually a randomized trial, which is rather pragmatic, does not require prior experience with Lisa. So we'll be smarter in a year or two.
Marty, if I can ask you, is it a head-to-head comparison comparing something like intubation or INSURE to less invasive, or is it that more strategic approach that allows you to say, I'm going to enter into treatment a little earlier because I have this minimalist approach?
Actually, it's a randomized trial comparing standard intubation surfactant administration to Lisa. So
Understood. At the same criteria, though, as okay, good, which is great.
I mean, I'd recommend, as Roger's always said, video laryngoscopy is such a really good technique, not just thinking of Lisa, but for actual training purposes. And, you know, the price of these things has come down quite dramatically. And so, you know, I really would recommend them. Cause quite a lot of difference on our unit because, of course, we're intubating fewer and fewer babies. So many of the trainees have not got the experience, and yet they can all be looking and with the one baby that you need to use it on.
Your panel is all of an era that intubated every meconium baby that passed through their nursery. Literally hundreds of unnecessary intubations. But let me tell you, you want to intubate someone, call Marty or Ann. I'll bet they can still do it better than your residents.
That is true. Under 10 seconds on one try.
Only with my glasses on, though, sadly.
Dani, Daniela Satraño, ¿querés hacer algún comentario? Y luego Pati.
Sí, buenas tardes. Muchas gracias al comité por la invitación. Excelentes todas las presentaciones. Quería preguntarle a la doctora Greenought, porque ella puntuó bien el SIMV en los muy pequeñitos, cómo aumenta mucho el trabajo respiratorio y entonces no estaría recomendado. Como es una técnica o un modo ventilatorio muy frecuente en nuestro país, y más allá de que podemos separar este grupo de los menores de 1 kilo, 1,5 kilos, si uno quisiera, sobre todo los menores de 1 kilo, ¿hay algún grupo de los chicos por ahí no tan chiquititos que usted piensa que uno podría usarlo, por supuesto siempre con presión de soporte, ¿no? Que con más seguridad por el tema de trabajo respiratorio?
Yeah, no, thank you for the question. I mean, I think SIMV and pressure support is very different from SIMV alone, because if you're using SIMV and pressure support, the baby is getting support on every breath. The ones where I mean, SIMV, you know, when I go on the ward, I go, no, Prof's coming and we've got a baby on SIMV. And, you know, she's going to give us a lecture. I mean, I do a lot of teaching on the ward round, but where I think it is relevant is when you've got a big baby, maybe a Mercurial Aspiration baby, who's got a lot of spontaneous respiratory effort, and you're trying to keep their CO2 normal. So if you put that baby on supporting every breath, the CO2 would come quite low down, even on low pressures. But I think if you've got a 600-gram baby or 25-weeker, then you do need support every breath.
Gracias.
Thank you. Gracias.
Buenos días a todos. Gracias por la invitación y gracias por impresionantes presentaciones que nos dejan muchas preguntas. Siempre me preocupó el tema en el que manejamos el volumen Tidal en alta frecuencia. Para los que desde hace muchos años lo manejamos en el SORMEDIX, éramos ciegos al volumen Tidal, y desde hace unos años, aunque no sea con volumen garantizado, lo vemos, y no siempre lo vemos también ajustado a un valor cercano al espacio muerto, ¿no? Al valor del volumen Tidal del espacio muerto. Entonces, un poco yo quería preguntarles si ustedes creen que en parte los trabajos en alta frecuencia, que no tuvieron todos los éxitos que nosotros esperábamos y que sí tuvieron en trabajos en animales, tendrá que ver con que durante muchos años no hemos controlado de manera eficiente o más segura el volumen Tidal en alta frecuencia, y estos nuevos modos ahora, como el alta frecuencia con volumen garantizado, nos pueden permitir esas oportunidades.
Well, if I may jump in, I think your point's well taken. We have, until recently, really had no good way to know how effectively or safely we're ventilating these babies. the more modern devices widely available throughout the world and hopefully soon as well in the United States allow us to combine the advantages of volume targeting with the advantages of high frequency ventilation. And I think that's ultimately going to prove to be the most gentle and safest approach to respiratory support. The problem with interpreting the literature with high frequency ventilation is that most of the trials are quite old and compared high frequency ventilation to relatively primitive modalities of conventional respiratory support. So until recently, high frequency had remained static while conventional ventilation had evolved and improved substantially. Now with the availability of volume targeting on high frequency ventilation, I think we can safely take advantage of both. And when combined with the optimal lung volume strategy, we probably have the tools to avoid superimposing old BPD, that is true lung injury, on top of the new BPD that's simply arrest of normal alveolar development that's probably inevitable in babies born at the borderline of viability at 23 weeks. So I'm sure others have.
Yeah, I mean, I was just going to say, I mean, the work we've done on in vitro in alveolar analog cells, and there was work about 20 or 30 years ago that I think we all ignored. The more you stretch alveolar cells, the more interleukin is released. And I think you're absolutely right that some of these early studies, we'd got no idea what volume we were delivering. We assumed it was quite small, but when in some of it, I mean, you quoted, Martin, the Gabriel Dimitri's study with us. You know, when you actually got into it, it wasn't as small as we thought. And so now, with volume guarantee, we are in control. You know, we can know what we're going to deliver. But clearly, we now need to see what that translates into. Just because we can do it doesn't necessarily mean it's going to be fantastic. It's got a lot of promise, but we need the studies, don't we?
Can I throw in a comment? Can I throw in a comment from the least knowledgeable person on the panel when it comes to ventilation? That is, it impresses me as I listen to you guys how complex it is and how quickly the technology changes and merges and becomes more nuanced, and the daunting task of testing this. So I'd like to share a fantasy. For point one, it takes a whole system to institute these new machines correctly. And you guys are incredibly bright investigators with incredible teams, but the rest of the world doesn't have that. And I imagine that ventilators and ventilator strategies should be tested as a cluster design where whole centers get the new technology in hand, get trained, and work on it for months and months, and not pretending you could swap out this one or that one or follow a baby differently. And, you know, again, total fantasy, but I'm just so impressed at the rapid changes in the capability and our understanding of physiology and what might improve outcome, but so difficult for us to prove.
Yeah.
Roger, you make a very important point, which is these ventilators are sophisticated devices. The engineers have done a brilliant job, but it's nothing more than a tool. And if we don't use the tool well, it's going to not give us very good outcomes. Your point's exactly to that particular issue. And there are many examples in the literature of studies that showed unexpectedly bad outcomes with technologically sophisticated interventions like mechanical ventilation. The most recent example of that is the Vichy trial, which applied aggressive lung volume recruitment strategy with oscillatory ventilation to babies with congenital diaphragmatic hernia, which of course is absolutely the wrong strategy. And the comparison group was ventilated appropriately gently with conventional ventilation. So whatever trials are done, nestled and otherwise, it's all about choosing an optimal strategy. There is, of course, the example of jet ventilation, where one study from Philadelphia showed very poor outcomes. And again, it was a matter of employing the wrong strategy in a population that was different than what the investigators were used to treating previously. So you're absolutely correct that implementation of these sorts of interventions is fraught with potential pitfalls, and it's really important that we do the appropriate training and that we can translate efficacy to effectiveness in real life.
Quiero compartir una pregunta del público que se refiere a la relación IE. Para Martín, digamos, ¿cuál sería el criterio de selección para tomar una relación 1:1 o 1:2?
Okay, so that's an important question. The probably both can be used in most circumstances. With the sensormedics, 1:2 ratio has always been standard, and there are probably some reasons for that. Under some circumstances, you can have distal pressures higher with a 1:1 ratio than the pressures that are measured in the circuit. So 1:2 ratio is somewhat safer and probably also results in less negative pressure within the lungs, which may be important in avoiding airway collapse. With a 1:2 ratio, you have twice as much time to suck out the tidal volume out of the airway as you have to inject that same tidal volume in. So the pressure gradient required to do that is going to be less. So it is interesting, but one of the things, if you look at all of the studies in the literature, the ones that demonstrated benefit, whether that's a real reason or not, I don't know, but those that demonstrated benefit used a 1:2 IE ratio. And the ones that used a 1:1 IE ratio often did not demonstrate a benefit in terms of bronchopulmonary dysplasia, although, as we saw, the long-term follow-up from the UCOS trial, even though there was not a short-term demonstration of reduced chronic lung disease, showed long-term improvement in long-term pulmonary outcomes. So that may be an exception to it. But I don't think we know absolutely for sure. With some of the devices that have somewhat limited power, 1:1 gives you more ability to generate a larger tidal volume, but we chose to use a 1:2 IE ratio in our study for the reasons that I explained. I don't know if Anne has any comments on that.
Dani, ¿quieres hacer una pregunta?
Sí, para el doctor Kessler. Volviendo a la ventilación por target de volumen, digamos, el tema de la compensación de la fuga y los diferentes marcas y modelos de ventiladores, que no todos funcionan igual, y eso puede ser parte del éxito o no de lo que hacemos. Entonces me gustaría que hiciera algún comentario más al respecto.
Yes, the leak compensation issue is a very important one. And not, as you said, not all ventilators are created equal. So I've worked with the Draeger devices for pretty much all of my career, and those devices have very effective leak compensation. Certainly the newest generation, the older Babylog 8000 Plus, did not tolerate leak larger than 40% or so, and then there was a risk of inadvertent overventilation if you continue to ventilate with a large leak. the VN500 and the newest generation has an extremely effective leak compensation that allows accurate tidal volume delivery with leaks up to at least 70%, which is really quite remarkable. Most of the other devices don't have the same effective leak compensation, so you have to be careful. You need to know your device. That's true under all circumstances. Know your device, know its limitations, and be careful. Obviously, volume targeted ventilation totally depends on accurate tidal volume measurement. With the Draeger devices, the tidal volume is actually calculated based on inspiratory and expiratory leakage, but it is very reliable, and it is one of the probably the biggest advantages. Some time ago, wrote an editorial advocating that we should maybe start using cuffed endotracheal tubes in our neonates because volume targeted ventilation was such an important issue. And then Draeger came up with their leak compensation, and I said, never mind, we don't need that anymore. Not at least not with that device. But if you have other ventilators that don't have the same magnitude of compensation, then it might still be an issue. Thank you for that question.
Thank you.
Bueno, vamos a tener que ir cerrando. Creo que no encuentro las palabras para expresar los orgullosos que estamos de haber contado con ustedes tres, que han tenido unas disertaciones excelentes y han sido muy generosos con nosotros, y también con la presencia de dos expertas de nuestro país, digamos que son referentes en estos temas respiratorios de hospitales públicos. Así que, la verdad, muchas gracias.
Gracias a
you.
ustedes.
Thank you.